So welcome everybody. Nice to have you here in this nice new building, Stanley Hall, which is a beautiful new building here on the Berkeley campus, and a beautiful auditorium on a nice night too. This is the annual Wildofsky Lecture, the Aaron Wildofsky Lecture. It's our signature intellectual event of the year at the Goldman School. We've had a series of very distinguished speakers over the years, many who went on to win Nobel Prizes. We are sure there's a causal effect there. And it works to our advantage because people sign up for this talk because they know that if they come here, they have a good chance of winning the Nobel Prize. So, David, I wanted you to know that, David. So, we just have an enormous influence. I wanted to, we're going to do a little tinkers to Evers to chance, and those who know your history of baseball know that's an old double play combination for the Chicago Cubs. Well, triple sometimes, but double play most of the time. It's a shortstop, a second baseman, and a first baseman. Anyway, so I'm the beginning of that double play combination. And so I'm introducing Lee Friedman, who's a distinguished member of our faculty who does research in a variety of fields, including cap and trade and energy policy, and is doing a very interesting study right now looking at questions having to do with how do we do a better job of monitoring the use of electricity so that we can maybe make electric cars possible by making electricity cheap at night when you would be charging your car and make it more expensive during the day when it's actually more expensive to produce. So Lee's doing some fascinating research, like frankly, all of our faculty members are doing great research. So it's a privilege to introduce Lee. He's the person who over the years has been the dynamo behind this lecture series. He's the person who's helped put the committees together that have chosen this truly distinguished set of speakers. And so it's really my great pleasure and honor to introduce Lee Friedman, who will then introduce our speaker.
Thank you, Henry. We actually do have a triple play rather than a double play tonight because I'm just going to tell you for a minute or so about the Wildofsky Forum itself and why we have it in its history, and then I'm going to introduce Professor Rucker Johnson, who will introduce our speaker to you. So welcome everybody to the 17th annual Aaron Wildofsky Forum for Public Policy. Before I tell you a little bit about what this forum is, I have two quick announcements. One is that if you have a cell phone, if you would kindly turn it off. And the second one is that following this lecture, we're going to have a brief reception right outside in the lobby. So everybody is welcome to stay and have some coffee and cookies and greet the speaker and speak your mind and relax. So please stay at the conclusion of the lecture. Aaron Wildofsky was one of the intellectual giants of 20th century social science. He was a political scientist, a founder of the scholarly public policy movement, and he was the founding dean of the Goldman School of Public Policy. He was an extraordinarily articulate person with strong views, often not popular ones, and he engaged scholars from all disciplines in a manner that was public, critical, exciting, and productive to the thinking of those present. He really personified the concept of intellectual community. And among many issues, he was fascinated by what he called the paradox of time in healthcare policy. He noted that our continued success in solving health problems caused people to live longer and then to have other problems that were harder to solve than the ones that had already been solved. So we always felt like the healthcare problems were mounting and that we were doing worse, even though we were really doing better, and that caused a very interesting political dynamic. To honor Aaron, we created this living memorial, the Aaron Wildavsky Forum. And our intent was to bring both intellectual excitement and community to the campus, as Aaron Wildavsky had so often brought to us. We've had many distinguished speakers, as Henry noted, like sociologist William Julius Wilson, psychologist and Nobel laureate Danny Kahneman, the economist and New York Times columnist Robert Frank. And our speakers publish books that come out in a series from UC Press. So just in the last year, in the last 1 year, we've had 3 books come out at once. In June 2010, Stanford political scientist John Bender published Bounded Rationality in Politics, a work that was originally stimulated by Aaron Wildavsky's great contributions to our understanding of budgeting. In February of 2011, Princeton social anthropologists Catherine Newman and Rourke O'Brien published their book, Taxing the Poor, Doing Damage to the Truly Disadvantaged, about the spread of regressive consumption taxes that are particularly burdensome to the poor, and they were located particularly so in southern states of the United States. And coming in August 2011 is a blockbuster little book by Becky Blank, formerly of the University of Michigan and Brookings Institution, now serving as Deputy Secretary of Commerce for the United States. And her book is entitled Changing Inequality, a deliberate double entendre. The first part is kind of explains what changes in inequality we've had in the past 30 years, with particular focus on how the changing contribution from women have caused changes in the aggregate statistics about inequality. And the second meaning is, if you don't like the kind of inequality that we have, what can we do about it? And the second part of the book is about how to change the amount of inequality we have. So all those books are part of what this forum does. We have the lectures, we have the books, and we try to bring some intellectual excitement to the campus in that way. I'd like to offer my thanks to the members of the Wildavsky Forum Selection Committee for this year's speaker, Professors Robert Reich and Rucker Johnson and Laura Stoker from Political Science, for their careful work and for their fine choice of this year's speaker. And I'd also like to thank Dean Henry Brady for his support of the forum, and Sandy Ketchpel for all of the work and logistical work in making arrangements for this forum, and the Goldman School staff and the school volunteers for all of their assistance in implementation. So our format is to have a lecture this evening with some time for audience questions and comments that Professor Rucker Johnson will moderate after the speaker finishes. Tomorrow morning from 9 a.m. to 11 a.m., there's going to be an extended discussion for those who are really interested and want more. And we have a fantastic panel of very distinguished people to comment on our very distinguished speaker. And this is going to take place in the main classroom of the School of Public Policy at the corner of Hearst and Leroy, room 250, GSPP. And you are welcome to attend that, of course. Professor Jane Malden will moderate tomorrow's panel, and our discussants will be former Michigan Governor Jennifer Granholm, Professor Richard Scheffler of Health Economics and of Public Policy, and Professor Will Dow of Health Economics. And tomorrow they will offer reactions to this evening's address, and following our speaker's response to those reactions, the floor will be open to everyone present. So at this point, I would like to to welcome Professor Rucker Johnson to the floor to introduce our speaker. Thank you.
Good. So we're very pleased and honored to welcome to UC Berkeley Professor David Cutler from Harvard to be the chosen this year's Aaron Wildofsky Lecture featured speaker. Professor Cutler is a renowned health economist and preeminent scholar in the field of public economics. He's currently the Eckstein Professor of Applied Economics in the Department of Economics and the Kennedy School of Government, and recently completed a 5-year term as Associate Dean of the Faculty of Arts and Sciences for Social Sciences. He has served on the Council of Economic Advisors, the National Economic Council during the Clinton administration. He's advised the presidential campaigns of Bill Bradley, and more recently was the senior healthcare advisor for the Obama's presidential campaign, and has very much been actively involved in healthcare reform in both 2009 and through 2010. And really, among other affiliations, Professor Cutler's held positions with the National Institutes of Health, the National Academy of Sciences, and currently is a research associate at the National Bureau of Economic Research and a member of the Institute of Medicine. And it's really the timeliness of the talk couldn't have been designed more perfect. He's the author of Your Money or Your Life, Strong Medicine for America's Healthcare System, published by Oxford University Press. This book was featured in New York Times magazine, and he was recently named as one of the 30 people who could have a powerful impact on healthcare by Modern Healthcare magazine. And so it's really the national importance of healthcare reform compounded with this current state of both federal and state budgets that makes our selection of Professor Cutler an obvious choice as this year's featured speaker for the forum. So it's without further ado, let us receive Professor David Cutler. And as we made mention, after the talk, we'll be fielding questions, so certainly fill out the blue cards that were distributed. Thank you.
Thank you. Thank you so much. Thank you for inviting me here and for the kind introduction. It reminds me of the time my former dean at Harvard introduced me once. I was speaking to a group of alumni, and he introduced me as a model professor. You know, a model teacher, model scholar, model researcher, and so on. And so I was very excited by this. So I went home and I told my wife, I said, Mary Beth, did you know that I'm a model professor? And she pulled out the dictionary and showed me that the definition of a model is a small replica of the original. So I'm glad to be a model professor. Actually, my wife gave me one other good piece of advice. She said, well, you know, this is a very, very distinguished talk and a very distinguished group. She said, David, when you give a talk like this, you can be either witty or provocative, and I would encourage you to be provocative. She's very helpful with that kind of advice, as you might guess. So I will try and be a little bit provocative. I will talk a bit about the coming healthcare transformation. I will remind you of the advice I was once given as a young economist by a senior colleague of mine. The advice was, if you give a number, like GDP growth will be 4%, don't give a year. And if you give a year, like what the economy will be doing in 2012, don't give a number. And if possible, don't give either. So I will try and uphold that rule as best I can and talk to you a little bit about healthcare transformation. Let me just start off by saying a little bit, which is I did not know Aaron Wildofsky, although I have read many of his works. I wish I did know him. I hope someday I will be remembered as fondly as he is. And since I was asked to give this lecture, I keep asking myself, why can't I be as productive as he was? So this is really quite an honor, and thank you. And I will try and honor him by talking a little bit about healthcare reform. If you are like most people, you are lost about healthcare reform. Everyone knows who these people are? The cast of the TV show Lost. They spent 6 years searching for the secret to healthcare reform. So I thought I would explain in slightly shorter than 6 years what it was that they discovered at the end. So here it is what they discovered. So if you look at the major issues in healthcare, there are actually 3 of them. The first one is covering everybody. I put that down as easy. What I mean by that is that it is not technically difficult to figure out how to cover people. In Massachusetts, we reduced the share of the population that was uninsured by 3/4. How do you do it? You make insurance be affordable for people. That is, you reduce the price for people who have low and moderate incomes. And you make it be accessible. That is, you make there be a place where people can actually go to buy it. And if you make it affordable and accessible, you cover the vast bulk of people. The hard part here is the part which I don't want to deal with, which is the political science end of this, which is how do you get the money for it? Who do you want to get the money from? How are you going to supply all that? The reason why we never covered people is not because we didn't know how, it's just because we weren't able to actually do it. I don't want to talk about that. What I want to talk about are actually the 2 harder things. So if you say, what is healthcare about? What is healthcare reform really in some nutshell about? It is about reducing the cost of medical care and dealing with the quality of medical care. And the cost of medical care we know is too high. I'll tell you a little bit more about that, although not much because it's well known. The quality is actually quite haphazard, and I will talk about that and talk about the relationship between that and cost. But when I say that these are hard, what I mean by that is that they're very, very difficult technically. That is, to understand why a system spends too much, how you could get it to spend less, what it would mean to improve quality while simultaneously lowering the cost. And so that's the kind of area that I want to think about. Let me just start off, though, by stating as clearly as I can what at least I perceive the premise of a lot of healthcare reform to be about. So the premise of healthcare reform is that medical care is inefficiently provided, and it's inefficient in such a way that it is both higher cost and lower quality than it needs to be. And I want to pause here because whenever, for example, the president does a town hall meeting on healthcare, and he says whatever he wants to say, the very first question is, well, if your daughter were sick, wouldn't you want her to have the best quality healthcare, or if your mother were sick, or something like that? And what's going through the minds of most people who listen to that, most analysts who listen to that, is that that is entirely the wrong issue. Because what we know is that the vast bulk of things we could think of doing to lower the cost of medical care, or at least a large share of the things we could think of doing to lower the cost of medical care, would actually come with higher quality. So the real debate we ought to have is not about whether 88-year-olds should get chemotherapy given a small increase in survival probability, but how do you both make people healthier and simultaneously cut costs? And I'll show you ways to do that and talk about what would do that. But the idea is that we should be able to improve the value of this system, not just lower the cost, but improve the value by modernizing healthcare. And so I really want to dig into some of what that involves. I, of course, need to talk a little bit about why we want to do that. There are a couple of reasons. One is, of course, that, as we all know, the federal budget is on a collision course. Federal spending is projected to substantially exceed federal revenues. The biggest part of that is not Social Security, which is a kind of minor blip on the issue, and it's not other spending, which is basically in this projection expected to hold constant. It's medical care programs, Medicare, Medicaid, children's health insurance, and the new exchange subsidies, all of which are, under current projections, going to be exceedingly high. And so, and the situation is no better at the state level. There are at least 46 states, I'm not sure how the others have gotten out of this chart, at least 46 states where state budgets are a mess, where they're trying to figure out what to do, where cutting health care is a very big deal. So what does it mean to think about cost and to think about quality? Well, let me first just start off by saying, what do we know about the value of healthcare quality? What do we know about cost? And there are actually two dimensions that I want to focus on. There's the clinical dimension, which is what you usually think about, which is, did the medical care that I get improve my health as much as it might have improved my health? This is the equivalent of, did the car that I just bought, does it work the way it's supposed to? And the second dimension is the service dimension, which is, what is the experience like for people? Do people actually enjoy the experience? I'm not sure I should say this with the governor of Michigan here, but I regularly ask audiences, which is more pleasurable, interacting with the medical care system or buying a used car? Most people find that a difficult decision, and they think that probably buying a used car is a little bit of a more pleasurable experience. And if so, what does that say about something we care about enormously? So on the service dimension, people will tell you when you ask them about the poor quality of service, the wait times and times to appointment. How many of you can email your doctor? Do you know what share of doctors nationally email with their patients? What share of doctors nationally email their patients? There are various audience participation parts of this, by the way. There are a few quizzes that are coming. This isn't Florida. You do have to vote. 5%. It's about 3%. 3% of doctors email their patients, which is smaller than the number of priests who regularly email their parishioners. And I believe it's smaller than the number of people who regularly email the Lord. It's not clear to me what answer they get, but then again, it's not clear what answer they get when they email their doctor either. People will tell you about lost test results, about how they had to repeat tests, how they got different advice from different physicians, all sorts of things that bother people. Okay, so how do we think about this? Well, let me give you an example. Let me give you a kind of my typology of how to think about the medical care system, and particularly the kind of cost and quality. And I want to highlight three aspects of that. But first, here's a sort of canonical picture of a person who starts off life healthy. Most of us do. They often develop chronic illnesses, and then those turn into acute episodes with subsequent post-acute care. And so this, in a nutshell, is what healthcare is all about. And then when people do get sick, and sometimes even when they're healthy, they use a variety of medical care services. Primary care physicians, specialist physicians, hospitals, labs, nursing homes, home health agencies, medical device companies, pharmaceutical companies, any number of different kinds of providers. And the way that we think about them all is literally in boxes. I mean, if you look at how Medicare pays for services, it pays by box. If you look at how Medicaid pays for services, it pays by box. If you look at how private insurance does it, it's organized by box. In fact, if you brought a doctor from the 1950s back into life today, so if you brought Marcus Welby back alive, he wouldn't recognize a single thing that his contemporary doctor did. That is, nothing that is done today is similar to what was done in the 1950s, but he would completely recognize the way that it was done. There's a primary care physician, and you go to that person's office. You sometimes get a referral to a specialist. You sometimes go to the hospital, or you get prescribed a medication, whatever it is. It's exactly the same structure. Very few things that are the same structure as 1950 are as good today as they were then. And healthcare is not an exception to that rule. So what happens? Well, of course, most of the money is here in the red areas. So if you look at healthcare, where do we spend the money? 75, 80% of healthcare dollars are in the red area. We spend money when people get very sick. The top 1% of users consume about 30% of medical services. The top 5% are about 60% of medical services. We spend money when people are very sick, either treating them when they're very sick or dealing with the consequences afterwards. Okay, so what are the areas of waste? The first area is we spend far too much in those circumstances. Examples are often better than economic theory, so let me give you an example. Let me just see if I have it here. Yes, I do have it here. If you look in the Medicare population, people over the age of 65, and find everybody who goes into the hospital for any condition, 1 in 5 of them, 20%, 1 in 5 will be back in the hospital with a substantially similar condition within a month. 1 in 5. Massachusetts, where I come from, is actually higher than average. California is pretty high on this scale. Oftentimes, they never saw a doctor and never saw a nurse in between hospitalizations. In the best healthcare systems, 1 in 5 becomes 1 in 20. And so right away, what you have are people cycling far too much. It's not that they want to be in the hospital. I've yet to meet a person who actually likes being in the hospital. It's that they wind up there. Now, it turns out, how do you get from 1 in 5 to 1 in 20? It's actually very easy. You have a nurse visit the patient. You have a nurse go visit the patient 2 or 3 days after they're discharged from the hospital. Are you taking your medications? Are you not taking the medications you were not supposed to take? Are you having any complications? Are there side effects that we should deal with? Is there anything I should check with the doctor about? Is there anything we need to coordinate? So there's an obvious question, which is, why is it that hospitals don't send the nurse out? So you can go ask hospitals that question, and I have asked quite a number of them that question. Why don't you send a nurse out? Would you care to guess what answer you get? I'm not paid to send a nurse out. So right away, you're seeing something which looks like the incentives here. Now, it's actually not that the hospital wants the patient back, although, by the way, they do make money off the readmission. It's just that nobody has any incentive to deal with the patient in the right way. All those boxes, there's not a box for a nurse to make sure you don't come back. So one thing you could do is you could create that box, or in some other way find an incentive to deal with that patient. So I would just want you to keep that in mind. That's an example. That example gets repeated many times over. We spend $30 billion fixing medical errors. We spend tens of billions of dollars. The readmissions are tens of billions of dollars. At Massachusetts General Hospital, where I come from in Boston, one of the great hospitals in the country, or at least it thinks it's one of the great hospitals in the country. When a patient has had cancer and they've done with the acute treatment and now they're on kind of monitoring, so they come to the doctor every month for monitoring, the doctor orders an MRI every month before the patient comes in, just so they can have a recent MRI of the patient. And 10 years ago, the rate of imaging in the Medicare population has tripled in the past decade. 10 years ago, they didn't get an MRI every month. If you ask the doctors why the appropriate cycle for an MRI is related to the phase of the moon, they say, gee, we have no idea. If you say to them, could you cut the rate of imaging in half by doing it every other month? They say, we've never explored that. If you say, could you cut it to every 6 months? And would you get just as good outcomes without exposing the patient to so much radiation? They say, I don't know. So there's no kind of looking at how do you deal with these situations. And so that's the first very big part of this. That's where the money is. That's where things go wrong. Second thing, we are very bad at prevention. Prevention almost always saves lives, sometimes saves money, or if it doesn't save money, it costs very little. Preventing people who are healthy from developing a chronic illness, preventing people with a chronic illness from having it become acute illness. The US is probably about average on this. We do well relative to France and Australia. We do very poorly relative to the UK and the Netherlands. You know what the UK and the Netherlands do better than the US? If the word nurse sounds like it comes up a lot, it does. What they do is they have systems of care that are not just you go to the doctor when you feel well. Feel unwell. They'll have after-hours doctor care. They'll have nurses deal with people. They will coordinate. So the key issue in all the different boxes is lack of coordination. What good healthcare systems do is they find a way to coordinate. Okay, whether that coordination is done by the government, whether that coordination is done by private insurers, whether it's done by providers, whatever it is. We know that we could do much better on this than we do. The third area is excessive administrative costs, which is again related to lack of coordination. The costs of dealing with all the different boxes and links between these boxes and the health insurance companies is about 10 to 15% of medical care costs. To put it a different way, most physician groups, including very big ones that realize economies of scale, tend to spend about 10% of all the revenue they collect just collecting money. Why do they do that? It's impossible to figure out when a patient comes in how much they're supposed to collect from the patient, what they need to do to get billed, to get paid by that patient, when the money came in, how it was related to what they did for the patient, whether the patient is really covered by that insurance plan or not covered by that insurance plan. If you call up your insurance company and you say, is David Cutler insured by you? They actually have no way of really knowing. There might be 7 David Cutlers. How do they know which one it is? Maybe it's David M. Cutler, maybe it's David B. Cutler. How do we really know? So the most basic transactions just don't occur very well. Again, the US is a huge outlier relative to other countries. Systems that work well tend to have much lower administrative expense than systems that don't work well. I told you that 10% of revenue is spent collecting money. It ranges anywhere from 5 to 15%. That's anywhere from 10 to 100 times more than any other business spends collecting money. So if you look at, say, how many employees does it require to collect, X amount of dollars, healthcare is enormously off the charts on that. Just to give you another version of this, if you ask what is the most common occupation in healthcare, the most common occupation is not doctor, it is not nurse, it is office support. I have my favorite example of this, which comes from North Carolina, Duke University Hospital, another great hospital, 900 hospital beds, 1,300 billing clerks. I feel like if I'm admitted to Duke University Hospital, I should get 1.5 billing clerks in bed with me. In Canada, the relevant number would be about 2. We're not going to do a Canadian-style system. We probably shouldn't, but it's a very clear difference in the administrative operation of different kinds of systems. I can tell you what all those 1,300 are doing, but you really don't want to know. By the way, a fair amount of what the nurses are doing is actually office support. So roughly 1/3 of a nurse's time is spent on documentation. Another 10% of nurses' time, by the way, for nurses in the hospital, people have followed them around with stopwatches. Another 10% of a nurse's time is spent running around the hospital looking for supplies where they're not that are not where they're supposed to be. So between all of that, we waste about 50% of the nursing time in the country. By the way, has anyone heard that we have a primary care crisis? Where people can't go get primary care and we're wasting half of the nursing capacity in the US? Just doing things that it doesn't need to do. Okay, so the underlying cause of this all is kind of lack of coordination, poor organization. Things are organized by box. That's actually not only is it inefficient, but it's actually not what people value. The last time I checked, most people did not care whether they saw their primary care physician. What they cared about is, did they get better? And the fundamental missing feature of all of this is, what is the incentive to think about the patient as a whole? How do you get the patient, how do you do what's right by the patient? Take a patient with chronic illness, take the diabetic patient. How do you make sure that they are successfully managed, and if something bad happens, you deal with that something bad? What this is essentially a complete reorganization of healthcare, if you think about it this way. It's how do you deal not with the boxes. What most of policy does is it deals with the boxes. What people want has nothing to do with that. What they want is for the care experience to work well. Healthcare will work better when we get away from thinking about organizations and get into thinking about individuals. And so fundamentally, that's the transformation that's going to have to take place, is how do you make the healthcare system focused on what an individual needs to do better rather than a series of organizations. So I want to walk you through a little bit of what that value transformation is going to mean. Let me start off by saying other industries have figured out how to do this. Productivity growth in the US, which was very high in the post-war era, then fell in the wake of the oil price increases in the 1970s, actually increased quite substantially in the 1990s and remains very high today. So productivity growth is now about 2.5% per year. The problem with the macroeconomy now is not that productivity growth is too low, although we'd always like it to be higher. The problem is that the rewards of productivity are not being widely spread the way that they were earlier in time. And I think that's what Becky Blank was talking about last year, if I can guess correctly. Nonetheless, productivity growth is very high. Would you care to guess where productivity growth is high? Anyone want to tell me which industries? I'm sorry? Manufacturing, yes. In fact, there are actually 3 kinds of industries. Who said manufacturing? In fact, there are actually 3 kinds of industries. One are the people who make you and bring you stuff. Wholesale trade and retail trade. By the way, there are 2 syllables that you need to know to understand productivity in retail trade. The 2 syllables are wall and mart. Okay. So what an enormous part of this picture is actually Walmart completely transforming the way that retail trade works. In fact, retail trade, which is the people who sell you stuff, retailing, used to be like healthcare. It was a cottage industry with high cost and haphazard quality, and it's now been incredibly systematized. Costs have fallen. Real incomes have increased in enormous extent because of that. So that's the first industry that's been extremely productive. The second one that's been very productive is the people who bring you computers and IT. Any form of information technology, software, hardware, computers, telecommunications, all of that has very high productivity growth. And then the third area that in the official data has very high productivity growth is securities and commodity brokers. Anyone know what these people are? That's Wall Street. So they turned out to be slightly less productive than we thought they were. Nonetheless, those are the 3 areas. Now, what do those industries do? Well, here's one model. To cut costs, we've moved the clinic to China. Please take a ticket for your flight coupon. Like my wife said, I could be either witty or provocative. And it would be far better if I stuck to being provocative. What is it that these industries do in common? Well, there was a famous economist named Leo Tolstoy. And Tolstoy wrote that all happy businesses are alike and all unhappy businesses are unhappy in their own way. I'm not sure if you caught that one, but it is true. And so what is it that happy or productive businesses do? Well, they really do 3 things. One is they use information a lot. They have the right information. Okay? If you ask what Walmart's secret to success was, Walmart was always ahead with information technology. So it knew what people were buying, how to reorder that, how to get it there cheapest, how to make sure it knew what was going on with various goods and other kinds of products. So it was and remains extremely good at that. Same thing is true about the productive auto firms. They're very good at that. About productive online retailers, they use a lot of information. They know exactly what's going on. Who's doing it, why they're doing it. No real firm would ever have very dedicated employees, i.e. nurses with 18 years of education, spending 1/3 of their time documenting things and 10% of their time running around the factory looking for things that are not where they're supposed to be. By the way, it's very interesting. You know what the documentation involves for the nurses? Just completely. You know what the documentation involves? Usually what they're doing is they're taking computer information, like what's on the screen in the patient's room, and they're writing it on paper. They then take that paper and they enter it in a computer. And that's 1/3 of the nursing time in the country. So that's one thing that successful firms do. The second thing that successful firms do is they have compensation oriented towards creating value. If you're in a service industry, you're rewarded for a good service. If you're in a manufacturing industry, you're rewarded for 0 defects. You're rewarded for what is the source of value creation. In healthcare, what we reward for is doing more. So the way a doctor gets paid is by opening you up, or sticking something in you, or doing something else like that. And so they do a lot of that. There's no payment for sending the nurse out. There's no payment for doing any kind of monitoring. There's no payment for having the diabetic patient not come in. So that's all underdone. Okay, so that's the second big area. And then the third thing that good firms do is they actually empower employees and consumers to help them get better. Think about the way Amazon.com uses your own information from other people to figure out what it is you'd be most interested in buying. Think about the way that at Toyota, any employee can stop the production line if they observe 1 defect. And the issue is not just correcting that defect, which they do, but figuring out why it happened and making sure it never happens again. So all of that is an example of empowerment. And the interesting thing about healthcare is that doctors have this incredible life or death power over the individual patient, and they feel completely stifled because the system they are in allows them no freedom. And what they get really mad about is a system that says you can't do what it is you want to do, even though at the individual level you can do most anything you want. In a nutshell, what health reform is about is that. So in the Recovery Act in 2009, there was $30 billion allocated to wiring the healthcare industry. That will ideally lay the foundation for getting information to the right people and making good use of it. And I want to come back a little bit to what's involved with that. But that was one deliberate strategy. It was actually the first part of healthcare reform, was to lay that foundation. What most of the Affordable Care Act was about, actually covering people is not that many pages. Regulating insurance companies is not that many pages. If you actually ask why that bill was so long, why that bill was so thick, the reason why it was so thick was that it was dealing with payment. And dealing with Medicare payment, because it's so complex, involves a lot of effort. And so what the vast bulk of the bill was about was setting us on a process, again, I want to come back to this, but setting us on a process to completely transform the way that medical care is paid away from institutions and towards thinking about individuals. And then the third thing is, what happens once you do that? And I want to come back a little bit to that. I think about this a bit as, again, I feel bad for saying this when the governor of Michigan is here. Think of this a little bit as the GM problem and the Chrysler problem and the Ford problem, which is that for 3 decades it was incredibly apparent that they were doing the wrong thing, and they never got their act together until they were on the verge of death to do the right thing. And the question is, how do we avoid that in healthcare? How do we manage to avoid? So I want to basically flesh some of these things out. Let me talk a little bit about information, which is that data. The thing about healthcare is that there's more data, more information than any other industry in the economy. We don't use IT there at all, but if we did use IT, we would be awash in data. Data on patient encounters, data on what works well at a broad level, data on which providers are better and which providers are worse. One of the things about industries where there's a lot of data is that actually organizing the data is incredibly important. Let me just give you an example of that. If you are a doctor and you have a decision support system that tells you anytime there is any possible adverse interaction of a drug, you want to prescribe a drug, an ACE inhibitor to a patient, is there any possible adverse interaction? You would get an alert about possible adverse interactions 95% of the time you tried to prescribe a drug. Because 95% of drugs could go wrong under some circumstances. Well, if you present that to doctors, they will get so fed up by that they will just click OK every single time. And they will miss the time where they're about to prescribe something that will kill the patient. So you need a very smart system to deal with that, to say, look, I'm going to separate out the 2% or the 4% of those that really truly are things I need to intervene in. What that means is that information is a huge industry. And in industries where information is huge, that tends to drive the industry. So you get a whole industry of people who analyze information. Think about how many people make their living analyzing stock prices. There's a whole city, it's called New York, that is devoted to that. And then think about how many people make their living analyzing which diabetic patients are going to do well with this drug and which diabetic patients are going to do well with this drug. And if your spouse is at home, is there a different treatment that's appropriate than if you're living alone? For which there's nobody who does that. So information will drive a whole industry. It's also going to change the nature of the industry. In every industry where information has become key, firms have gotten bigger. Walmart took over retailing, Bank of America took over banking, legal services got bigger. And we're actually seeing that in healthcare, where in most big cities, big hospital systems are large. So in the typical American city, 1/4 of all hospital admissions are to the largest system, and those systems have 1/3 of the profits. 1/4 of the system, 1/4 of the patients and 1/3 of the profits means they're doing better, so they're going to get bigger. And so healthcare is going to get bigger. Now, bigger firms have a greater capacity to internalize, and so that creates opportunities, not just challenges. And the question is how to take account of them. And the way you take account of them is by saying not use your leverage to charge high prices and to do more, but use your leverage to coordinate care. And so you have to combine the information infrastructure with the infrastructure about payment. And this is really where, in many ways, the heart of healthcare reform over the past year has been. I want to show you what I think is coming, both because of the legislation and even independent of the legislation. So here's an obvious thing to do. Come back to our patients who bounce in and out of the hospital. And there are a couple things you could do. One is you could pay for nurses. So you could say, I want to have a nursing care transition program where nurses come and visit patients, and then they prevent the readmissions. Or the other thing you can do is you can just go to the hospital and say, look, I'm going to give you one price. When that patient shows up the first time, you get one price. And if that patient comes back, I'm not paying you. I don't care. I'm not paying you. And I'm going to build in some readmission rate. So I'll build in a 10% readmission rate. So I'll take your current payment, I'll bump it up by 10% because I know that readmissions do happen. Things just go bad. They do happen. But I'm not going to pay you any more. And by the way, while I'm doing that, I'm not going to pay the specialist who does the operation separately. You're going to work out an arrangement with that person. And if you feel like you need to send the person to a nursing home, you do that, but it's part of the same payment. If you feel like they need home care monitoring, you do that. It's part of the same payment. What have I done? I basically just bundled the acute care episode. And the reason to do that is because then someone is thinking about what's the right mix of services there. How do I save money off doing that? I would be very surprised if 5 years from now, this isn't the norm. If 10 years from now, the entire industry hasn't gone this way. No more boxes here because the boxes are just way too wasteful. Think about, here's a woman, she showed up in the hospital with a hip fracture. Who's going to care for her for the next half a year of her life or next year and a half of her life? We'll give one amount, you figure out how to deal with it. That's an easy thing for doctors to do. It's a straightforward way to start, so I would expect that we'll see some of that. You can go a little bit broader and come to the chronic care patient. Here's a woman not who is in the hospital with a hip fracture, but a woman who has osteoporosis, and she's at risk for falling and breaking her hip. Who wants to care for her? We'll give you a fixed amount of money. If you can figure out how to help her not break her hip, you can make a lot of money. You being whoever organizes this. By the way, there's a quiz coming up for who's going to organize this, just to warn you in advance. Or you can do an organization as a whole, what's called an accountable care organization, which is an organization that will manage care for the entire patient for an entire year for a fee. Just last week, the federal government, the HHS, came out with its proposed rules about what these organizations should look like. They're basically conglomerations of physicians, hospitals, nursing homes, any group that wants to, that feels it can provide care for patients, to accept a fee and be at risk. If they can save money, they get to keep some of the savings. If the person costs more, or if on average their patients cost more than you expect, they don't get paid the full amount of that. So there's some benchmark amount. You do better than that, you get to keep some of the money. You do worse than that, you don't get all of the money paid to you. And it's a way of creating an incentive to deal with these patients better in a way that doesn't happen now. And if these organizations really do well, what they'll think about is, how do I prevent the patient from going down the pink path? How do I prevent the pink path from becoming red? How do I deal with the red path once it's happened? Not guaranteed to work, but that's some of the ideas. We will also do a lot of performance-based payment. Half of the insurance plans in the country use some form of performance-based payment, particularly for primary care physicians. This is the easiest one to think about. You're dealing with diabetic patients. A marker for bad care is they show up in the hospital or in the emergency room with a diabetic emergency. Just pay them money if the rates of complications for their patients go down. Ding them if the rates of complications are high or they go up. Okay? Think about what are the metrics of good care, good chronic care management, dealing with patients. We actually know how to do this. It's not very complicated. It turns out that you can do this fairly well. The way that the best organizations do this is literally they have nurses come in the morning. The nurses get a list of every patient who showed up in the hospital last night, who's been admitted to the hospital. They figure out what was wrong, what went wrong, what do they need to do. They set that plan in motion. That goes until 10:30 in the morning. Then they get a list of all the patients who were in the emergency room but were not admitted. They figure out what went wrong with them, how do you need to deal with them, what services do you need to provide, how do you prevent that from becoming bad. That goes until mid-afternoon. Then they deal with all the patients who haven't refilled their medications because they have the information to know which patients haven't refilled their medications. So they call them, they say, do you need the new medication? Tell me what's going on, how can we help you with this? And you just work down from the highest cost down into other people, and you wind up improving the quality of care and saving money. It's actually not that difficult to do, it's just that nobody does it now. So here's your quiz. Who is best positioned to do this? So if I say to you, I want to pay money for managing chronic illness or even just a healthy person, who will do that? Atul Gawande will do that. He doesn't have enough other jobs in life. Community health centers. Would you like the multiple choice version of the quiz? Okay, here's the multiple choice version. You're a primary care physician. How many vote for the primary care physician? Because they're so good at managing things in general. The hospital. Who says the hospital will do this? The insurance company. Big fans of insurance out here. So far, very few people are voting. Lest I remind you, you do have to vote. Google or Microsoft or Apple. Someone else entirely. If you ask me, I would say probably the last one. And what that means is that there will need to be, under any of these, there will need to be tremendous organizational change, tremendous organizational innovation. And that's really what's interesting about this, is that if you look at the hopes of healthcare reformers, I like to be optimistic, they're going to throw me out of the Dismal Society Club. But if you look at the hopes of healthcare reformers, what they actually envision is not an evolution towards something that looks a little bit better, but an evolution towards something that is completely different. Or to put it another way, if the healthcare system looks the same a decade from now as it does now, then it's virtually guaranteed that healthcare reform will be a failure. And we will probably repeal the bill we just passed if we haven't repealed it before then. Where would I start? I would start with very high-cost people. I would start with Medicaid folks. I would start with dual-eligible folks. I would also start with people who have high-cost or discretionary common conditions. Cancer, think about the imaging that happens every month, where if you made it every other month, you'd save 50% of all the images. Lower back pain, most people with lower back pain go to see an orthopedist, then they get an MRI, then they get surgery, and then they get some physical therapy. It turns out only step 4 is needed for 95% of them. You can cut out the orthopedist, you can cut out the MRI, you can cut out the surgery, you can go straight to physical therapy, and 3 weeks later the patient will be better. That's not true for all cases, it's true for about 95% of cases that you can pretty well identify. And the best healthcare systems have figured out how to eliminate the expensive stuff for 95% of the patients. The only problem is they nearly go broke doing so. And the reason is that all the money comes from the orthopedist visit, the MRI, and the surgery, and the physical therapy is actually a money loser. So in order to make ends meet, they go to the insurance companies and they plead to at least make the physical therapy pay for itself as they get rid of all that other stuff. So these are where I would be looking for the savings. There are a couple of ways to think about the analogy here. Another analogy is retirement management. So there are a few things you want to manage in life. One would be your health. Second would be your money for when you're retired. There are firms that charge you a lot of money to manage your money for retirement. So they make sure that your employer deducts the amount you're supposed to and it goes to the right mutual funds and that the tax reporting is done and all of that, and they charge you a fortune for that. There is nobody who does that in healthcare. And I want to again give you an example. How many of you are caring for an aging parent or a child with disabilities? Okay, how many of you imagine that that's in your future one day? How many of you would be willing to pay $15 a month for someone to do that management for you? How many of you would be willing to pay $15 a minute for someone to do that for you? Why can you not get that? Why do you have to do it on your own? Imagine if you were responsible for managing your own retirement and you had to make sure that the money got from your paycheck to every single company, to every single mutual fund, that all the tax reporting was done, that all of that happened. You would hate the system too. Again, an example of lack of organization. So don't think of them as diseases, think of them as profit centers. How is this going to happen? Well, there's one view which is just that if you get the fundamentals right, the rest will take care of itself. I actually don't think this is quite right because of the GM and Chrysler problem, which is that we knew forever, they knew forever, that they were doing it wrong, and they never really changed. And that's true about most industries. Walmart nearly drove every single retailer out of business. It drove a lot of them out of business. It nearly drove all of them out of business. It might need financial pressure. I hope it does not come to this. There are about 5,000 hospitals in the country. If we have to threaten to bankrupt 4,000 of them in order to get them to change, that would be really, really bad. So I hope we can find some way short of this. It turns out, as I noted, that Walmart kind of spurred change throughout the economy, and you can see sort of sales per employee going up at all the competitor firms, all of retailing. If you do these surveys of how good are the managers who run firms, retail is off the charts. It's incredibly good managers, because otherwise you're just dead, you're just out of business. That's not true in healthcare. Healthcare is very poorly managed by these surveys. There's a different view that what you need is just good leadership, and that we need good managers. Healthcare is perhaps the hardest industry to manage of any industry in the economy, and the people there are trained the least well in management. There's a quote here which I like, the bottom quote, which is from a doctor who runs the physician network at Partners Healthcare, which is the very big healthcare system in Massachusetts. It's dominant. The Attorney General made a point of saying how much money they charge that they shouldn't be charging and all of that. So the fellow who runs the physician network, he's a physician. He wrote an article in Harvard Business Review. This is his very first sentence of the article. The problem with healthcare is people like me. Imagine if I wrote an article, the problem with universities is people like me. Doctors, mostly men in our 50s and beyond, who learned medicine when it was more art and less finance. So it may be that what we just need is better management. The difficulty is that we don't have a ton of good managers that are out there. So I don't know what we would do if it came to this. Although there are some examples of importing managers. So Caritas Christi in Boston, which is the Catholic system, was bought by the people who ran Chrysler for a while. Detroit Medical Center was bought by a subsidiary of Vanguard. In each of these organizations, the actual purchase price was very low. What they were promising was investment in management, actually. A different view is that none of this will work, and that what's going to happen is we're just going to put the existing firms out of business, the way that Walmart put Main Street businesses out of business, or the way that Amazon.com put bookstores out of business. Maybe the iPad really will take over the primary care physician, and we just won't need any primary care physicians. I met one the other day. It was great. I didn't know there were any primary care physicians left. Wanted to take his picture. Apollo Hospital, which is a hospital in India, it serves the roughly 400 million Indians who can afford to pay $5,000 for bypass surgery. So you can take a vacation to India, have bypass surgery. That's at the level of approximately the 90th percentile American hospital. They get accredited in all the right ways and stuff like that. You can visit the Taj Mahal and come back, and it's still cheaper than doing bypass surgery in the US. Maybe they'll just rent a boat and stick it outside of New York Harbor and do bypass surgery on the cheap while you get a tour of the Caribbean. I don't know what it will take, but one way or the other, the management will have to keep up with this. So what we are in the process of doing is fixing the incentives, and then the question is, how is the organization going to change? I want to highlight this in one other way, and this is your final quiz, and that is, what do these people have in common? There's Mr. Cook. You can see him, a jolly old fellow. What do these people have in common? Most of them, although not all, founded healthcare companies. 3 strikers and you're out. Do you know what the strikers make? I'm sorry? Yeah, they make orthopedic stuff. So, in fact, you are right. These people are in healthcare and they are rich. They are the members of the Forbes 400 richest Americans whose money comes from healthcare. And I've shown you here what they make their money doing. The common theme to all of these folks, essentially all of these folks, is that they make their money by inventing new and fancy ways to treat you. They make their money by sticking it to you or sticking it in you. That's how people have made money in healthcare. Let me show you a different list. These are retailers on the Forbes 400 richest Americans. There are 6 Walmart heirs, 5 descendants of Sam Walton, 1 other person. The combined heirs of Sam Walton are worth more money than the entire previous page. There are 2 Home Depots, 3 Gaps, a Best Buy, a couple of supermarkets. Anyone live in a town with a Hobby Lobby? You have to be from the Midwest to see. I saw one actually once. I wanted to take a picture, stick it next to the primary care doctor. How many of these people make a product you use? None. So how did these people get rich? How did they get rich? These people are phenomenally wealthy, and how did they make their money? They made their money by changing the way that the system is organized. And what they did was they drove out costs that didn't need to be there, and they kept some of that as enormous profits. That is the fundamental difference between what's happened in healthcare and what's happened in every other sector of the economy. Is in the one way you make your money by putting stuff to people, and the other way you make your money by running things more efficiently. Our best guess, come back to those wastes and the costs, our best guess is that on a $2.5 trillion healthcare system, we're wasting anywhere from $700 to $1 trillion a year. So whoever can figure out how to coordinate care, streamline medical practices, overhaul the administrative processes, make sure people get what they should get, manage the information flows, do all of that, the potential is there to make in 1 year 10 times what Walmart is worth as a total. Now, they're not all going to do that. We're not going to get rid of it right away. But that is the phenomenal potential. And it's going to be done the same way that other folks did it, which is thinking about what do people want. And at this point, yes, people want more stuff, but what they really want is to get better and to have the focus on them and to not waste resources. And so the hope is that if we get this right, that's what will come of this. Lest you think this is too hard, I will quote to you another famous economist named Jerry Garcia. And Professor Garcia said, "Somebody has to do something, and it's just incredibly pathetic that it has to be us." Which is a little bit how I feel about this. So I am going to stop here, and I want to hear from folks in the audience and get a few reactions.
So the first question we have is...
I have to interrupt you. There was a dime on the floor, so I might make a dent in the California state budget.
We'll take it.
So the first question we have is, should economists care whether Obamacare is unconstitutional?
Should economists care? Of course, some people think economists are human beings too. It's widely derided, but it is true. So on that metric, they should care. But yes, let me tell you a little bit why. Let me deal with this. So I gave you a view about how healthcare reform will work well in tackling the hard issue of how do you save money and improve quality. And the question is, if you disagree with that, what would you say? So there are basically 2 other views. There's the view on the left. I'm going to walk around. So there's the view you get from people on the left, which is that the only model that we know is successful is a kind of single-payer European-style model. That's the only international evidence we have. So forget about what you're saying in Obamacare. That's what we know. The view that you'd get on the right is that the only model we have from every other industry in the economy is that consumer choice drives success. And what made Walmart successful was it was selling to people who were paying their own money, and that's what made productivity elsewhere in computers and so on. And then somewhere in the middle is this idea that it's kind of neither of those, but it's about how you're going about running the system. If Obamacare is repealed, we've gotten rid of that one. And the question is, what's left? If you thought the fight over Obama, the Obama health plan was bad, imagine the fight over should we have a single-payer health plan or should we have substantially less insurance and more of an individual kind of choice. That would be bloodier than anything I've ever seen, and it's really, really scary to think about. So the alternative to making what we're doing work is almost unconscionable. It's almost unimaginable.
Okay, I'm going to go to, please comment on the necessity of medical malpractice reform to allow the coming transformation.
Medical malpractice reform. There's this very funny split where if you ask every doctor, what is it that drives what you do, they say it's malpractice, fear of being sued. And if you ask any health economist or any analyst how much medical malpractice and defensive medicine contribute to health costs, they'll tell you it's about 4%, out of a total waste of anywhere from 1/3 to 50%. And I have no idea who's right. I do think this, though. I think we should have done more malpractice reform in the bill, or we should do it now. And the reason is only partly because we want to save money. The other reason why is because what we need to do is practice medicine in a completely different way, and that's a very wrenching change. And while we're doing that, we'd better be doing something to reassure doctors that we're really on their side and we want it to work for them. And one thing they absolutely desperately need in order to feel that way is that malpractice won't kill them. By the way, another thing they need is to reduce administrative costs. And on both the malpractice end and the administrative cost end, I think the administration was weaker and Congress was weaker than it should have been. And it could have engendered a lot more, both in cost savings and in goodwill, by being much, much stronger.
We have a pretty huge list, so I haven't had a chance to organize them, so I'm just going in the order that they've been given. I'll try to coordinate them soon, but this is from an MBA, MPH candidate. And their question is, you mentioned that the new innovative firms will do the care coordination. What would they look like, and how do we foster or drive their creation? This is a candidate who wants to help lead or at least drive that change, and they want to see what the role that they could play.
Someone who wants to be a billionaire. So you want to be a billionaire, right? It could be a new TV show. Of course, if I knew, I wouldn't tell you. I had this great idea once. I thought I should be a business school professor, so I had this great idea. I said to myself, what are the 2 most common uses of the internet? Everyone know what they are? Healthcare and pornography. So I said, imagine if you could combine those 2 interests of people. Just think about what all the money you could. That was when they told me I should go back to the economics department. You know what's funny? So if I had to guess, I would guess that what they will be is actually firms that are very significantly tied to physicians. That is, they're organizations of primary care physicians and specialists where what this firm is doing is it's running their IT systems, it's running their basic communication systems, doing refills and patient scheduling and all of that. It's doing contract management, it's doing quality assurance. And so it's kind of almost a cooperative type arrangement amongst physicians and the folks they work with. But I'm stressing the physicians, and here's why. in any competitive industry, the folks who do well are the people who provide the skills that you absolutely want, that the customer absolutely wants. What is it that the customer wants here? It's actually not a hospital. They don't really care which physical building they go to. What they want are the specialized people who can help them figure out what's wrong, what to do about it, and how to do it. And that's the MD power and the nursing power. It's the people. So I think that the bidding will be, in essence, for the people, not the buildings. And right now we're seeing a bunch of hospitals thinking they're going to be in charge of this, but really they're just not, because that's not what people want.
I'm going to give a set in a row.
All right.
So that we can try to get through a series of these. And then we'll try to group them. But I just want to read a series of these, and then we'll respond to them kind of correspondingly. So one is, aside from size, what are the main differences between healthcare and higher education? And here they're noting low quality, and they're maybe mentioning teaching, and the high growing costs as similar aspects.
Yep.
I have, so maybe we'll start there.
It's a great question. Those are two industries that have migrated into the public sector, where they're intensely important to people. They have very rapid cost growth, and they're perceived to be not very productive. By the way, in the official data, healthcare is negative productivity. That is, in the official data, we spend more to get less. And they're both areas where we think we could improve productivity. I think actually healthcare is in some sense easier to envision where the poor productivity is, because we know the outcome pretty well. The outcome is you want to be healthier and you want to enjoy the service as much as possible. And but you see many of the same things. So for example, the information to know who's doing well and who's doing poorly. Well, what most states are doing now is trying to figure out which schools are doing well and which are doing poorly, and which principals are good and which principals are bad, and school districts. So they're starting down many of the same paths in terms of the information, trying to change some of the incentives, trying to figure out how to make things run better.
That's right. That's right. So I have this series. One is, what role and responsibility does current regulation, big labor, trial lawyers play in the slow progress of disruptive innovation? That's one question. I have one that's, if there's so much room to make a profit in healthcare, why hasn't anyone made it yet? Discuss the role of physician culture. I have one that's about, not expectedly, this is someone, I think, questioning a little bit of the economic view of the emphasis of incentives. And they say, most of your talk has been about using monetary incentives to change practice, but that hasn't necessarily worked in the past. They note a number of examples, and they want to understand, well, what about cultural changes in the healthcare that are needed to happen for the financial incentives to be effective? That is, if the sole focus on financial incentives, in what ways are those incomplete to see the changes we want? Maybe we should start there. And the other, I guess, linked question might be, bundling sounds like capitation. How do we avoid under-provision in each year? So I understand. I'm just trying to get through a series so that you can at least see some of the connections, because some of the questions certainly have overlaps.
They do have overlaps. These are all great questions, by the way. These are all incredibly important questions. I can give you a little bit of a sense of what the policy debate was like, which is, there are a couple of facts that people had in their mind that were driving this. One fact is that physicians and other providers respond incredibly highly to incentives. And let me just give you one example that's rolling through people's mind. In the early 1980s, the Medicare program went from paying for every day in the hospital to just paying a fixed amount for a hospital stay. Okay, so it went from every day, got paid $600, to every day cost you $600 with no revenue. And the number of days in the hospital fell by a third within about 2 years. Phenomenal change. And when you looked at it, the patients were no more likely to die, their health was no worse, it appeared they just eliminated unnecessary, extra long hospital stays that weren't doing anybody much good. And not only that, that system created winners and losers, because there's some patients who are sicker who you know are going to stay longer, and other patients who are healthier who you know are going to leave sooner. And so there was every incentive to take the sick ones and to dump the healthy ones, or take the healthy ones and dump the sick ones, and they didn't do it. There was no real access, no big access problem. And so people inferred from that, and from a variety of other things, that incentives have a huge effect, and that the culture of medicine is strong enough that you don't need to worry about massive skimping, cheating, under-provision. So that's kind of, that played out as, okay, I'm not that worried about it, and I really want to drive these strong incentives. Now, as this happens, you're going to be changing the physician culture a lot. And the question is, will you get rid of that good culture, which is, it's my job to take care of people, and even if I'm going to lose money on this person, I need to do that? I don't know. I do know that, if you extrapolated, that's the answer you get. By the way, the answer is completely different about insurance companies, where they seem never to respond to incentives to do better, and they're really good at selecting people. Which is why an undercurrent of all of this is, you insurance companies are not doing anything good, let's get rid of you. Let's make the doctor system be kind of like a small insurance company, and you take over that function. And if insurance has disappeared 15 years from now, who the heck cares?
So that speaks to a related question, so you're already addressing it, but it's about what do you feel would be the role of self-insured corporations in healthcare? So it's a related point.
It's exactly related to it, which is a lot of this is going to be about cutting out the middleman. If I were in the health insurance industry, I would be very concerned because they have not figured out how to provide any service that anyone actually wants. They're not really bearing much risk. Every big firm is bearing their own risk. Small firms will get together and exchange. They're not bearing much risk. They're not doing much in the way of steering you. They're not helping you improve your health. They're not giving you any service that you'd actually want to pay them for. They may just disappear just because they can't think of anything to sell.
Mm-hmm. So this has certainly spawned a pretty interesting set of questions. Here's another. I have never heard anyone in healthcare talk about benchmarking, which is used in industry. Industry benchmarks themselves against their competitors. We never saw healthcare benchmarked against Canada, France, UK, and others. Each one has some strengths we could incorporate into our system. Please comment on the approach, that is our limited approach, and maybe not taking enough inventory over what other countries are doing in our benchmarking.
Ooh, it's a great question. Let me tell you actually about benchmarking, not other countries, but within the country. So if you look at where the best care is provided in the world, it's actually, I think, not in another country. It's in parts of the US, like the Mayo Clinic or the Cleveland Clinic or Kaiser out here for some things, or other Geisinger Healthcare. If you go to Partners Healthcare in Boston and you say, why aren't you as good as the Mayo Clinic in terms of holding down costs and fewer errors in hospitals and so on, you know what they'll say? They'll say their patients are different. They're not as poor, they're not as inner city, they're not as whatever. There's just no way we could get there. If you go to them and say, how come you still have an error rate in your hospital? It's 4% error rate or whatever it is. They'll say, look, at a big institution like ours, we just can't get there. By the way, the University of Pittsburgh has a 0% error rate. So you can get there. But there's this incredible denial. Now, it turns out when you then publish the data, they can all of a sudden get better. So Michigan did a project, you probably sponsored this project, on ICU safety, which is where they came in and they did report cards for all the intensive care units on the number of central line infections, which are basically infections because you haven't been careful about how you put in the thing and you haven't changed the dressing and so on. And when they started publishing it, the rates of infections went way down. These are massive, huge infections that you really don't want. They went way, way down. So you can shame you can incent, you can threaten. They all tend to work. We don't do very much benchmarking because we haven't had the data. And you also have to have a measure that the doctors really believe. And actually, the leading folks on this are the cardiac surgeons, who are quite happy to benchmark bypass surgery, angioplasty, because they came up with the measures of how sick the patients are. And if I were doing this, I would go to the societies and say, either you come up with a measure for how we can grade you, or we'll come up with a measure for you. And your measure will probably be a bit more accurate, but if you don't want to do it, I'm happy to do it for you.
Mm-hmm. So this set of questions is really related to what you had a little bit touched on, which is, are there organizations in healthcare that are now doing what Walmart did in terms of modeling these new approaches? How close, for example, does Kaiser Permanente come to fitting your model of the new firm? And could you explain, because you had a slide on malpractice, explaining that, but the organizations that right now we would maybe describe as modeling this new transformation.
Mm-hmm. Kaiser is a very good model for some things. What it's an extremely good model for is this upper part. How do you keep patients healthy? So it turns out to be very, very good at that. Where it falls, where consumers don't like it, is when they get very sick, they're worried that they can't go to where they want. So there's an upper limit to Kaiser enrollment, which is about 1/3 of the market, and it never seems to go higher than 1/3. There's then an interesting and hard economic question, which is, can you replicate what Kaiser does, but not have people always come to one building? That is, can you make virtually what works in a bricks and mortar organization? The most successful firms tend to be brick and mortar things. And that's a little bit troubling about whether you can do it, but if you can do it, then you can get rid of the big limitation of those kinds of systems.
Mm-hmm. So this question reads, as seen recently in the retail and financial markets, the revolution of the healthcare market will bring huge profits. Considering the goals of the industry, do you think the federal government should manage this transformation to distribute health equitably and efficiently and by economies of scale? So it seems to be touching also on the administrative costs and how the economies of scale can be breached. We tend to forget it now, but at one point, Walmart was the world's most hated corporation. I'm sure Bob doesn't forget. I don't think it's been forgotten here in California. At least not in Berkeley, maybe.
And it was hated because of what it did to other firms in terms of putting them or almost putting them out of business. And one of the reasons why we have government is to prevent the huge dislocations that may come. Here, again, you're not dealing with Sears where it's a few employees and something. You're dealing with the local hospital and the local medical society and the local pharmacy and all of that. That could be an utterly wrenching transformation. So the government will have to be involved because of that. And quite honestly, it will also have to be involved for monitoring safety, monitoring that consumers are really getting what they should be getting and not being skimped upon. Mm-hmm. So what's interesting about this, when people talk about big government, I mean, as I laid out the vision here, it's actually not about government, it's about the private sector, but there is this absolutely central role, which is if you're going to go through change, make sure that it works for everybody.
Mm-hmm. Mm-hmm. So I hear a related question here that seems to be about one thing that's different about healthcare is the information asymmetries that are different than other commodities.
Yep.
And the question really is about will the kind of managed care or what you call accountability care organizations make care worse by offering less? Similar to the claims that HMOs cut too much care and the kind of cream skimming selection that goes on? What are the safeguards given the fact that we want to empower consumers, but it's a dynamic where the patient has much less information about those aspects? That's how I interpret the question.
So actually, this question has come up a couple of times where people have said, isn't this just managed care all over again, and so on. How many people remember fondly their experiences in managed care? Actually, in California, people might. How many people, by the way, are in Kaiser? About a third, roughly the California share. How many of you that are in Kaiser regret it? How many of you who are not wish that if you could start over, you would be? People seem actually fairly comfortable with what they have. That's actually true nationally. Most people are comfortable with what they have. Here, let me tell you the difference, though.
And can I just add an adjoiner here?
Absolutely.
Because it's related, that the further kind of adjoiner to this question is about how would you set fees?
Yep.
Assuming that those fees will be lower than the current healthcare costs, wouldn't providers strongly resist the pay cut? What do you believe can actually convince providers to make the pay-per-value profit?
Yep. What we tried a decade or so ago, 10 to 15 years ago, we tried having insurance companies beat up on doctors. So Cigna would run an insurance plan, Aetna would run an insurance plan, go beat up on the doctors to get them to do less. Well, in a fight between an insurance company and a doctor, we saw who won. The doctors won. What's interesting here is this is not being set up as a fight between insurance companies and doctors. What it's being set up as is, if there's a fight, it's a fight between primary care and specialty care. That may be a nasty fight. I'm not saying that'll go well, but it's actually a fundamentally different one. And the issue is going to be how to regulate that. Now, that's why all the specialty care is trying to buy all the primary care so that they control them and they don't get played off that way. And if they do buy it all and stuff, then that won't necessarily happen. But this will be a very interesting dynamic. That could be good. It could be bad if you don't want your physician to feel conflicted about what to do with you. I don't know how exactly it's going to play out. We tend not to worry about the primary care doctor skimping on you. And we probably think the specialist won't really skimp either. So we're probably okay, but there's one other thing that's going on which is actually quite important here, which is that absent doing something like this, what every doctor in the country is thinking and what every hospital in the country is thinking is that their fees are falling. So you have in the legislation a reduction in the hospital payment increases by 1 to 1.5% a year. You have the fact that physician fees are supposed to fall 25% later this year, and we always kick that can down the road by 2 weeks every time, but they're still supposed to fall. So they're all scared to death that if they don't do something, there will be a massive change. So actually it's not that bad if you want change, because what's happening is, on the one hand, we're giving them a really big stick. We're hitting them really, really hard. And on the other hand, we're holding this out and saying, do well and we'll share the money with you. And so there's a lot of interest in doing this because everyone believes the future is untenable otherwise. And it's actually much easier to get interest. I guarantee you, there's not a hospital or a health system in the country that has not thought about how they want to respond to this. Not a single one. Whether they do it right, I don't know, but there's not a single one that is not intensely concerned about it.
So we'll just take these last two, and then we'll try to kind of move to the reception. But this question really is, do you think the implementation of the Affordable Care Act is actually sufficient to still be to put us on the path you describe? And in particular, are the new regulations of the act sufficient? And then in terms of policies that would incentivize providers, especially the small clinics, to implement the electronic health records and other IT improvements? Because of the economies of scale and such a transition, how do we ensure that the smaller clinics are able to make that transition?
They won't, they'll get gobbled up. There's an kind of unwritten view of most policy folks that by a decade from now, there should essentially be no more small doctor practices. That they should just be part of bigger groups, either real groups, like they're in a group with 50 doctors, or a virtual group. And that virtual group will be providing a lot of the services for them. People don't really talk about it that much, but that's clearly the sense of a lot of folks, is that model is not tenable. Well, I'm sorry, remind me of the
first question was about, do you think the Affordable Care Act is sufficient to put us on the path that you describe? And is it sufficient?
You know, I sort of, here's the score I have in my mind, which is 10% of going from where we are to where we need to go is the actual legislation. 25% is the implementation in Washington of that legislation. And 65% is, do the people in the industry do the kinds of things that are hard but that have to be done? And I worry a little bit less about what will Washington do, in part because I trust the people in this administration more than I trust the people in Republican administrations. And I worry a lot about what it's going to take to actually get the job done when we set down to do it. And I am intensely, intensely worried that we don't set up the GM, Chrysler, Ford situation all over again. And I wish I knew how to prevent that. I understand how to write good regulation. I understand how to pass laws or develop laws. I don't know how you prevent healthcare systems from going the GM route.
I guess I'm going to interject my own last point,
Please
or my
do.
own last question, which is, coming from Massachusetts, what were the lessons learned from Massachusetts healthcare reform in terms of what aspects of the lessons learned were incorporated in terms of, as you advised the president, what aspects of the Massachusetts experience were critical for how you developed your thinking in these regards?
Massachusetts legislation is extremely popular in Massachusetts. So by 3-to-1 margins, it's very popular. One of the reasons why we voted for Scott Brown is because we didn't want the federal government to do anything that would upset the Massachusetts legislation. What we did was we covered people. We said, we've got money. We have money that we had stolen from the federal government that they were going to take back. We had money that we had raised in taxes that we weren't doing much for, money that we had raised. So we used it to cover people. We purposely put off any discussion of costs. So we purposely put off any discussion of how we're going to save money. As a result, we focused on one thing, covering people. We did it well. People are very happy. It worked extremely well. It provided a model. You could no longer argue that they were going to spend $1 gazillion and not cover people. That argument just disappeared because it wasn't true. What you could argue is, yeah, but the thing won't save money because we don't yet have any proof other than the Mayo clinics and folks like that. We don't have any wide-scale proofs of here's how you go from not doing it to doing it. What's happening in Massachusetts now is a debate that will hopefully lead this year to a bill which everyone is calling Healthcare Round 2. And Healthcare Round 2 is dealing with costs. And the governor's proposed a bill, and the Senate president wants to move the bill, and the Speaker of the House will move the bill if he gets his casinos and racetracks. And everyone is thinking of that as the next phase. And there's this sense that Massachusetts wants to lead the country again, having shown the country how to cover people, now show the country how to save money.
Okay, please join us in thanking